Good afternoon. The time is 2 o'clock in the afternoon. This is the voice of Tehran University of Medical Sciences, School of Dentistry. Okay, we have interesting lectures for you now. The second and last panel of community oral health will be within next 2 hours from now. We start today with topics in the title of the risk assessment or caries risk assessment. And then we have 2 lectures for evidence-based dentistry. And the last one is about social determinants of health. The first part is provided for you by Professor Afsaneh Paktaman. the faculty member of Community Oral Health Department in Tehran University of Medical Sciences. Dear Dr. Parktaman, the floor is yours. Please start.
Thank you very much, Professor Hesari. Good afternoon,
A bit
everybody.
louder.
Good afternoon, everybody. My topic is caries risk assessment, and we are going to go through some aspects of caries risk assessment in dental setting. First of all, we talk about some definitions. If you don't mind, I'll just go through my slides and then I will continue.
Okay, could you?
Okay, thank you very much, Dr. Hesari. We just go through some aspects of caries risk assessment, which is suitable for dental students and also is good for to be implemented in dental practice. First of all, I'm going to talk about some definitions, and then I'm go through some descriptions of risk factors and risk indicators. Sorry. In fact, why we doing assessing the risk of patients? Imagine that you are working as a dentist in a clinic, and then you do like a long span bridge for a patient. If you do not assess the risk of the patient and spend hours and hours just doing the bridge work, then you will confront with the problem that the patient may have like a recurrent caries in the abutment of the bridge. So it's very important for us to have an estimation of risk of the patient. How we can doing assessing the risk of the patients? Imagine that in a population that most of the people are caries free, it's not going to be effective to assess the risk of the patients. Also, in a population that there is anybody with disease, this is no matter and no indication of doing a risk assessment. But in population where a large proportion are caries free, but some individuals still have caries active status, it is very important to focus to take care of this target population. So assessing the risk of the patient is important in this population. I'm going to talk about the definition of risk, first of all. Risk is the probability that some harmful events will occur. To predict the new caries or harmful event, we have to go through some factors. The importance of properly predicting the occurrence of disease is obvious, as the target preventive actions can be directed to those persons having a high risk of caries, and scarce resources can be properly utilized. In 1998, Professor Beck has definition of what is risk factor. Risk factor is some environmental, behavioral, or biologic factors defined in longitudinal studies and has some impact on the outcome, which is the caries. These factors increase the probability of the disease occurring, and if absent or removed, so the probability of the disease can be reduced. Risk factors are part of the causal chain or exposure. So if we delete some of these factors, so that the disease can be prevented or postponed. In a new textbooks of cardiology, this is the diagram which we thought to talk about what is the factors influence the caries. As you can see in the black circle, we see some indirect factors like social class, so like income, education, behavior, knowledge, or attitude. So these indirect factors influence the most probable factors, which are saliva, diet, fluoride, and composition of the microbial species in the mouth. This is important diagram because it influences our concept of the caries. As you can see, it is very complicated disease. Some risk indicators, which is shown in the black circle, influence the middle ones, which is shown in purple. The black one, we call them risk indicators, which I'm going to explain about them. And the purple one, they are risk factors or biochemical risk factors, which we go through them comprehensively. This is a case that Professor Nivad puts in the cardiology textbook. What do you think? He's a 28 years old man who ignored oral hygiene and has been sipping sugared coffee regularly during the day for 5 years. As you can see, he's not a smoker, he's not addict, but he's got caries in a very, very high caries status. When the patient visits the dentist for his mouth, the dentist informed him that he had 2 risk factors, having sugary snack and also ignoring oral hygiene. So you can see that being very high risk patient is very close to us. All of us has to be informed of the caries risk factors and risk indicators. Otherwise, we might have a problem with our patient or even with ourselves. So I'm going to talk about risk indicators of the caries, which you seen in the black circle. Risk indicators are some factors that influence the caries process indirectly. As you can see, socioeconomic factors are very important that increase caries risk. For example, if a person is socially deprived, has no work, has bad economic, or might be has low level of education of parents, and also he has not the situation to get knowledge about oral health, and also because he has no work, he has no regular insurance system, so he has no regular checkup. This might influence the risk of the patient. So risk indicator in this case is socioeconomic status. So as you see, so the caries is a very complicated process. So socioeconomic status is one of the risk indicators influence the caries. Another risk indicator influence the caries process is general health. You might see patients with some general disease, and they might have some medication. Also, you have to bear in your mind that general health influence oral health. So people with general disease, they have a higher risk of getting tooth decay. Also, there might be some handicap in patient, mental handicap or physical handicap. So handicapping influence the risk of the patient. I'm saying these factors because in your patient visit, you have to consider that if you have patient from low socioeconomic status, or you have patient with a systemic disease or handicap, she or he might be in higher risk of getting a tooth decay. Another risk indicators that comes in the literature are some epidemiological factors or circumstances that might increase the caries risk. Imagine that a baby born in a family with high caries level, he or she is automatically in higher risk. Or living in high DMFT country or living in high DMFT area. So these things like circumferential factors influence the case. Why? Because the family has got some habits, and the baby automatically will have these habits, so he will be in higher risk of getting tooth decay. But imagine that we go through the literature to see which of the factors is the most important factor to predict the caries risk. Literature says us that high past caries experience is the best predictor for future caries. So if the child has high caries in BCD's dentition, he or she will have higher risk of caries in permanent dentition. Also, when we look at the intraoral of the patient, if we have early lesions, a lot of caries, a lot of fillings, or having like a lot of white spot lesions, this patient might have some higher risk. So clinical findings also help us to indicate the risk level of the patient. So if there is some locations that dental plaque will trap, like when the patient has newly erupted teeth, or has exposed root surfaces, or has crowded teeth, or even have some natural retentive sites, like between the teeth, or retentive sites by dental treatment, like overhang or denture or partial denture. So this patient has higher chance of getting dental plaque, and definitely has higher risk of getting tooth decay. So looking at the intraoral finding of the patient helping us. But on the whole, literature says they are risk indicators. They are not risk factors. So they have some indirect role in getting tooth decay. But what are the biochemical factors or risk factors of the disease? Factors that you saw in the purple circle, they are biochemical risk factors. So the dose and also the duration of getting involved with these factors are important. Here is a list of biochemical risk factors: amount of plaque, type of bacteria, type of diet, frequency of carbohydrate consumption, saliva secretion, saliva buffer capacity, and fluoride exposure are very important factors that influence the risk of the patient. Here is a checklist of biological and environmental risk factors, which comes in the recent cardiology book. Medical history of patient, current and past dental care, medical history means current or past disease of the patient, current medication, which may cause xerostomia, are very important factors influencing the risk of patient. Dental history of patients, which means current activity states of caries lesions, past history of caries, also oral hygiene status, exposure to topical fluoride from toothpaste, rinse, or tablet, and current dietary pattern influence the risk of patient. So the important question is that which factor predict caries, and what is the overall estimation of caries risk by clinician? So here are the checklists that influence the saliva secretion, which you can see the medication that the patient use, like an antidepressant, antipsychotic drugs, or anti-Parkinson drugs, or very importantly, antihypertensive drugs influence the saliva secretion. So they may have xerostomia. And also some systemic disease, as you see, Sjogren disease, diabetes, scleroderma, or some aspects of life, like during pregnancy or during menopause, patients have xerostomia. But very important is having asthma, drug abuse, and smoking. These patients are very high risk because they get quickly caries, and the progression is higher in these. And most importantly, having a neck and head radiotherapy or chemotherapy which damage the salivary glands. Here is some examples of how to examine the patient xerostomia. If you invert the lower lip, you can see that the secretion of a minor salivary gland. Also, there are some chairside kits that you can choose to use visual inspection of salivary secretion. If you see the salivary salivary under 16 seconds, so this is a very good situation. Or if the consistency of saliva is watery clear, this is a good situation. Or the pH is between 6 and 7 is a normal situation. Or the quantity of the saliva, which means that in 5 minutes you will have 5 milliliter of saliva. So these situations are low risk situation. Or also you may assess the diet situation. If you have 24-hour recall questionnaire, you can quickly pick up how many snacks between meals the patient will have. If the patient have 3 to 5 between meal snacking, so it's okay. But higher than that, the patient is in category of high risk. Also, you will look at the plaque situation of the patient, and also how the patient gets fluoride. You know that fluoride is discovered in the early 20th century, and a person called Dr. McKay reported on Colorado stain, which these stains that he saw on the teeth of the patient. As you know, this is a fluorosis situation. It means that if the patient gets a higher level of optimum level of fluoride, as you can see in this slide, in different cities, they evaluated the level of fluoride in the water. As you can see, higher than 1 ppm, the patient has a lower DMFT, as you can see in this graph. But what is the optimum level? The optimum level, as the references say, is between 0.8 to 1.2. Below that, the patient cannot get enough benefit from fluoride, and above that, the fluorosis may happen. So fluoride is the most important element in that dentists try to use, and this is very obvious that it is a natural, and it's we have in some concentrations in the water. Seawater may have 1.2 milligram per liter of fluoride. And also there are some situations that the fluoride level is very high. Like in Tanzania, we have some water supply of 25 ppm. So what is the good level or the optimum level? Less than 1 ppm is the optimum level of fluoride that we recommend. So what is the action of fluoride? Is a systemic effect, pre-eruptively or post-eruptively, and topical effect. So if we use a systemic effect of fluoride, we use water fluoridation, which is very safe and effective way of using fluoride. So many countries has that in their water supply, like United States, New Zealand, and Australia. And it is effective, it is safe, and it is inexpensive. So public health consider that an ideal public health method. So this is a good finding. The discovery of fluoride helps us to add that in our water supply. However, some countries are against this method. If we use that in our water supply, we can reduce the caries in permanent and deciduous dentition. But the major effect is in children. Adults can benefit from that very low. And also some countries like United States, they use a fluoridation of school water, which is another way of using fluoride. And also we have fluoride tablets, which is chewable tablets. It is not that much common in nowadays, but there is like a guideline used by ADA or AAPD that if we have water supply of less than 0.3 in children around 5 years old, we can have a half of a tablet each day. And also there are other vehicles to use that systemically, like fluoridated salt and also fluoridated milk. Another way of using fluoride is professional application of fluoride, which is started from 1941, when a worker in his laboratory experiment observed that fluoride ion and enamel react with each other and make fluoridated fluorapatite. So this is a method that is nearly 40 years used by Scandinavian countries. So the most important vehicle is fluoride varnish, which we use more than 35 years in a Scandinavian country. It is very highly dosage, like 22,600 ppm. This is in fluoride varnish, so it should be used with care. Fluoride varnish with like a Durafart fluoroprotector epoxylite, they are commonly used in the market. And also we have systematic reviews that assess the effectiveness of fluoride varnish. So the effectiveness is 38% reduction. We can use it in children, we can use it in adults who have a xerostomia. And the interval of use is 3 months, or we might use it every 6 months. If we use it for children, we have to floss interproximal contact between the teeth, and also say children not to eat anything for half an hour. For preschool children and also for handicapped children, it's very useful. And be careful that a fluoride varnish is best applied when the child has food in the stomach. So the position of the children in the unit and also having some foods before the session is very important. Also, we have fluoride gel and fluoride foam, which has 5,000 to 12,300 ppm fluoride. This is also recommended to be used by dentists in dental office. You can use that with a particular tray, which we use. And if the patient is adult and has xerostomia, also in adult patient, we can use fluoride gel or fluoride foam. Another way of using fluoride is for home use. You know that a fluoride toothpaste is very important. After 1917, this is the very important vehicle that is recommended to be used for prevention of tooth decay, and also fluoride rinse. Fluoride rinse has some benefit, but it's less than fluoride gel and fluoride varnish. So for daily use of fluoride, we have a mouth rinse. So, but the concentration is less. It's 0.05 sodium fluoride. And for weekly use, we have a bit higher solution, like 0.2%. So the reduction of caries is 25 to 28% using a mouthwash. We have to consider that we cannot use that in children under the age 6, because the swallowing reflex is not complete in these children. Be careful that it can be used weekly, and it shouldn't be swallowed if the children is using that. So assessing risk of the patient in clinical practice is very important, because it somehow guarantees the success of your work. If you don't know how assess the risk, you cannot predict the speed of progression of the disease, and your treatment might be influenced by those factors. So as a whole, we get patient history, we get dietary screening, we look at the inside the mouth, we see the caries status and history of the patient. We looking at fluoride exposure and saliva of the patient and tooth morphology. It is nice to have a bacterial load, but it is not recommended in some papers. Thank you very much for your attention, and I'm just say goodbye to you and wish you luck in your career.
Thank you, Dr. Khochbin. That was a nice presentation, a lot of information that was necessary for all of the dental students to use them in routine clinical practice. So if anybody has a question, please raise hand and or write it in the chat box. No question yet. Okay, somebody raise hand, please. You can speak.
Okay. Hi, Doctor, and hi to the lecture doctors. I'm really appreciated. I have one question very fastly. There is a group of people live in the same place with a normal environment, and they took normal fluoride in their water, normal concentration of fluoride. They have healthy diet, they eat healthy food, and they don't drink cola, Vanta, these things. But they have caries. If the doctor will say to me because of pH, so I will say to her that the saliva and their pH was the thing that affect on it. Thank you so much.
Thank you very much. If you just explain your question again, because I couldn't hear your voice, or type a few words, so I will go through that. Thank you.
Doctor, a group of people live in the same place with normal environment. They are drink normal water with normal amount concentration of fluoride. They are eat healthy diet. They have healthy diet, and they didn't drink like Lavanta, these things, but still they have caries. All of them, they have caries with all of this healthy environment. If you will say to me because of pH in their saliva, so I will tell you what's the thing that affect on the pH in their saliva. Thank you.
Thank you very much for your question. Actually, I understand that you're talking about a community which live in a, which have a normal diet and they use normal water. It is very difficult sometimes to assess the risk of at a community, because you have to look at why these people get higher level of caries. Maybe the level of fluoride in the water is not optimum, like less than 0.8, or maybe they have some habits. It has to be clearly evaluated. Otherwise, we cannot say that. Usually, the people do not care about their oral hygiene. They do not have access to optimal level of fluoride, and they have sugary diet. These people has higher risk of getting the disease. Otherwise, maybe there's something in their environment which we should investigate more deeply. Thank you. I hope that I answered your question. Thank you.
Thank you, Dr. Paktuman. And certainly, as you mentioned, there are so many factors that should be evaluated. He mentioned some of them, and we should carefully evaluate the other factors also. And there is another question that I want to ask: how often we should conduct caries risk assessment for a patient? Is there any definite answer for that?
As I said in one of the slides, the best predictor of the risk of the patient is past dental caries. Some guidelines talking about how many caries with obvious cavity is in the mouth. If the patient is high risk, so 3 months has to be, the schedule. So we have to evaluate again the patient every 3 months. If the patient has no risk of this situation, like a medium risk or low risk, then we can extend the interval. So this is no definite rule in the literature. As you see, the guidelines on caries risk assessment are growing at the moment. So they are just building up on the literature, previous literature. Also, I see that my students Asoma, hi Asoma, he has some questions. Can you talk about your question here?
Okay, Soma, if you want, you can raise your hand and.
Or you might type it.
Oh. Okay, you can talk if you like.
Yeah. Hello, doctor.
Hello, Asoma. How are you?
I'm fine, thank you, doctor. Good afternoon.
Good afternoon.
Yeah, I was the one who asked about how often caries risk assessment should be done for a patient. Yeah, that was my question. Yeah, but one other question I have is that in the first slide that you presented, you said that if you have a population where majority are caries free, but a minority is high risk, then you should conduct a caries risk assessment. But my difficulty is when you are in a place where the exact caries prevalence is not known, but you happen to see cases that are usually few but highly advanced, is it necessary to conduct caries risk assessment?
Well, I hope I understand your question. You ask that in a situation that is in a population that is new to you, you don't know the caries status of them. I think according to the guidelines, if you look at the inside of the mouth, if you see a frank cavity, which means that a patient has an obvious cavity without any filling, then you might start following the patient as a high risk patient. So just implement the preventive protocols and follow them up, and then reinforce your advice, your preventive advice. Then little by little, the risk of the patient is getting lower, and then you come up with that person getting medium risk or lower risk. Then you can stop, follow the patient. Thank you.
Thank you, Dr. Paktaman. Thank you. If there is any question or no question, thank you anyway. And hope the audience enjoyed the presentation. After a short break, we continue by the next presentation.
Thank you very much. Good luck. Thank you.
Okay, for the next part, we have a presentation by Professor Mohammad Reza Khami, and he continues the topic that started yesterday on the evidence-based dentistry. Dear Mohammad, please, the floor is yours. Start.
Okay, thank you, Hossein. Hello to everybody. I hope you have attended fruitful times, fruitful hours in this winter school from the morning till now. So I hope you are not tired and you are ready for the competition that we started yesterday. So the international competition of evidence-based dentistry. Okay, so today we will continue the topic. The topic of my
Mohammad, sorry.
Sorry.
Could you please take your mask and speak louder, please?
Okay, what about protocols then?
Okay, ask the others to keep away of you.
Okay, so
and open the windows, please.
Here. Okay, so
better, very good.
Yes, thank you. So my topic is about the principles of critical appraisal of different types of studies and articles. Before that, just I try to review what you have learned about evidence-based dentistry yesterday. So let me share my screen and go to my slides. So, and then we can continue. Can you see my slides now? Okay, can you see my slides now?
Yes, that's okay, that's okay.
That's okay. So if you remember, we talked about, yesterday we talked about some cases first, and then we came to the components and definitions of evidence-based dentistry. So we have seen these slides yesterday. These were the 5 steps of evidence-based dentistry, as you remember surely. And then after me, you had some lectures on how to define a clear question with all the necessary components of PICO. And then my colleague, Dr. Shamshiri, explained about how to find the answer, how to search the literature. Today, we mainly want to talk about appraising and critically appraising the evidence. So first, I talk about principles of critical appraisal, and then my colleague, Dr. Shamshiri, will continue with how to interpret evidence. Okay, so you know that we have four main types of questions about therapy, diagnosis, prognosis, and causation. And then now I want to come to and you know PICO. Now you can remember PICO, patient or problem, intervention, if there is any comparison group or comparison intervention, and then all of our questions should have a specific and certain outcomes. Without outcomes, we cannot search effectively, and we cannot come to an answer to our question if we don't define the outcomes from the beginning. So, and then where's the evidence found? Dr. Shamshir talked about this. Okay, now we want to today competition and presentation. You know that how we acted yesterday. So this is the question. You will raise your hand and you will answer the question, and then you will say from which country you are, and a score of that questions will go to your country. And at the end of the competition, and with summing up the scores yesterday and today, we will announce the winner of the competition. So first question is, How many types of epidemiologic studies do you know? Please name as much as you know, as much as you heard about epidemiologic studies.
Do they have? How many minutes do they have?
Okay, because of the time, I think we can spend just 1 to 2 minutes for each question.
Okay. Should raise hand or just write the answer?
Please raise your hand.
Okay,
I want
your
the students to raise their hand and talk.
Who is the first one?
Do we have any volunteer to answer this question?
Are you sleeping?
Very easy question. This is a very simple question.
How many types of epidemiological studies do you know? You
State of your country. Just raise your hand. The first one can get a good score, because now we don't have any volunteer.
So nobody. Who is the first one?
Yes, now we have one. Okay. So.
Hi.
Hi.
Yeah, I guess there should be 4 types: cross-section studies,
yes,
case control studies, and intervention studies, and cohort studies.
Cohort studies. Yes.
Yeah.
Okay. Thank you. So you are from?
Sure thing. I'm an international student from Azerbaijan. I'm actually from Iran, but I study abroad.
You are studying abroad. So
yeah.
Are you playing for Azerbaijan team or for Iran team? Please decide now.
That's a tough question.
Yes.
Tough decision to make. I don't know.
You are a legionnaire, so you can play for Azerbaijan team, no problem if you want.
Yeah, sure.
Okay. So
Thanks.
you are playing for Azerbaijan team, and a good score you could from the first question. Okay. Anyone wants to complete this answer or not? Any other? Okay, so
3 participants.
the next one, the next student.
Yes. Hello. Nice
Hello.
to meet you again. I think that I can say also experimental. I think this is also one of the types, and observational also.
Observational and experimental.
Observational, yes. And just like a previous participant said, it's a cross case. It's also interventional.
Yes.
Intervention, yeah. And I think, yeah, I just wanted to add experimental and observational.
Okay, very good. And you are from?
Azerbaijan.
Azerbaijan. Oh,
Yeah.
Azerbaijan teams is coming up. Very good. So, and the next students, maybe just one student again can answer this question. One more student, please.
Nobody else? Yes. Okay.
Yeah, we have volunteers, don't we?
Okay. The next one can speak. What's the name? Fatima.
Do we have any other volunteer?
Mohammadi. Fatima Mohammadi.
Very good. So
Microphone is open. Okay. No voice. So finished. The time is over. No.
okay.
Finished.
So we will go to the next question. Are you ready? Okay. So we want to know how many criteria do you know? Do you remember about how to criticize an article, how to criticize a paper?
Okay.
Which criteria can you mention regarding critical appraisal of the literature?
Who's the first?
And then you have the opportunity to just doing a search. Okay, so we have now one volunteer. Asuma, please. We are hearing you.
Who is the one? Raise hand.
Hello.
Hello.
Yeah. I think the most important and only, the most essential is to look at the methodology employed in a study. And that is gives you the most important point of view as far as the quality of that study is concerned. Thank you.
Yes, I agree. I agree. Maybe the most important part of an article is its methodology, and it should be sound. So you are from Ghana,
Yes,
and you're
Ghana.
studying in Iran. So for
Yes.
which team you are playing now?
Well, anywhere you place me, it's okay.
Okay, so you should
Ghana,
decide.
Ghana.
Very good.
Yes.
Okay, the other one is
The next student. Who is the next?
Behnaz. Okay, Behnaz.
We are hearing you.
Muhaddis Panahi.
Has a group control to see whether if the effects that and the results are the effects of our interventions or not, whether the environment has affected or not.
So, so you first mentioned about the results.
Yes, I wanted to say we should have control groups.
Control groups. Okay. Do you think that in all studies we need a control group? In all types
I
of
think
studies?
the studies with interventional.
Interventional. So
yes.
we need a control group in interventional studies. Is there any interventional study without control group? Have you heard about that?
I don't know.
Okay. So you mean that in the studies that they need to have a control group, we should have a control group. And okay, then there are some criteria about how to select the members of control. Okay, thank you. And you are from?
Yes. Iran.
Iran. From which university?
Gilan University.
Gilan.
Okay.
The other one is Darina Timokina.
Yes.
And the last one, please.
Yeah, we are hearing.
Good afternoon. I think the general criteria to criticize an article are research novelty, relevance, and large sample size, and the ability to apply the results to humans.
Okay. Okay. Thank you. Thank you. There are so important criteria. Thank you. And you are from?
I'm from Ukraine, Kharkiv National Medical University.
Okay.
Yes.
I have visited your university. Very beautiful and very good university.
Thank you.
Do you continue, Muhammad, or is the last one?
Yes, maybe
one more and the last one.
Just one more. Okay.
Ran Saleh. Okay.
Hi, how are you?
Okay.
Hi.
First of all, I would like to thank you for your time. My answer would be is that we would judge the discussion, the results of the study, the review, what was used in the study, the keywords that were used in the study, and the limitations that were in the study.
Okay, thank you. Thank you. And you are from?
I'm from Palestine.
Palestine. Okay, very good.
Okay. Thank you. And there is another one for the next question, please.
Yes. Please, yes, because of the time, we should go to the next question. So, thank you. And the next question is about, okay, what do you know about the hierarchy of evidences? Okay, let me explain about this question. as some of you mentioned, we have different types of studies. For example, observational studies. If you want to make it in two categories, we can say that we have observational studies and interventional studies. And in the category of observational studies, we have case control studies, cohort studies, and cross-sectional studies. And in the category of interventional studies, we have randomized controlled trials, yes, and quasi-experimental studies, two main categories. And if you want to sort just these types of questions to know which of these studies produce more valid and reliable evidences, we want to talk about this. So what do you know? So this makes the hierarchy of evidences, okay? So what do you know about the hierarchy of evidences? The first participant.
Okay.
The first participant.
Hanahi.
Okay.
Hello, doctor.
Yes.
Hello.
Hierarchy of evidences, that's a pyramid that contains different level of studies. At the bottom of this pyramid, we have experiments which are done on the animals and the laboratory studies. In my opinion, that's the most original studies, because these evidences has vital references, and it can have good results.
So at you are talking about the bottom of the pyramid, or the bottom of the Yes. So and you think that at the bottom we have experimental studies, yes?
Yes, because in the bottom of that pyramid we have animal and laboratory studies.
Animal and laboratory studies. Okay, we'll talk about that. So thank you. And you are from?
I'm from Iran, but I'm Azerbaijan University student.
Okay, and what about you? Do you play for Azerbaijan team or Iran team? No problem, you can decide.
Okay.
I don't know.
You don't know?
From Azerbaijan.
Yes, I'm Iranian, but I'm Azerbaijan University student.
Okay, so
the next one, Mohammed, is Noor.
Yes, next student.
Noor.
The next student.
Okay, the Marcarius Tantoir. Okay.
Hello.
Hello.
Actually, before I will answer you, I will say to you, really, I appreciate that you are really know how you make the lecture interesting. You know, you make all of us, we are so tired. You make all of us enjoyable and excellent about to take your knowledge. My answer about your question, about the question, it's the questions. For example, when we are doing the experimental, we must discuss with the teachers, with the doctors, with the people that high experience than us. Then step by steps, we will reach to the results or the evidence, and at the end we can take and observe high results.
Okay, thank you very much. Thank you. And you are from
Iraq.
I'm from Baghdad.
Yes. Iraq.
And the next one and the last one, or
yes, the last student for this question.
Marcarius.
Yeah. So the talking about the level of or the hierarchy of okay, my video. Okay. Talking about the hierarchy of evidences, I think first the one at the base is the expert opinion. Then from there we can go to the, how do you call it, the case control studies. Okay. So that's moving up the pyramid. Okay. So the expert opinion is at the base of the pyramid. Then we have the case control studies. Then I think cohort studies comes. The rest I'm not so sure. But for the one at the apex is the how do you call it, the systematic reviews. That is the one at the apex of the evidences.
Very good. And you are from?
He is from Mars. From Mars.
From?
According to the background, he is from Mars.
So we have some participants.
I'm from Ghana, but I'm actually an MD student in TUMS. So.
Okay. So
yes.
You are from Ghana. Very good. Very good. I think you answered very well. So, okay, thank you. And we will go to the next question. Okay, so do you know what is systematic reviews? Just I want to explain about what is systematic reviews, and then you can, maybe many of you know what is systematic review, but just I explained
yesterday,
very shortly.
Yesterday Ahmad explained the systematic review.
Okay, so you know that what is systematic reviews. So what do you know about the criteria to critically appraise systematic reviews? This is the question. What are the main criteria for critical appraisal of systematic reviews?
So, Asoma is, okay, Asoma.
Yeah.
Okay, Asoma.
Hello.
Yes, yes, I hear you.
Yes. I think that for appraising a systematic review, you need to check, like doctor mentioned earlier, the PICO, the PICO guideline, whether there was a clearly stated question for the study, for the systematic review, and then the inclusion and exclusion criteria, whether it was, completely included all studies, and then studies that were not supposed to be included were also excluded, and then also the result, whether it was precise or not. And then also I think the most important aspect will have to do with whether the result of the study would be beneficial for patient care. Thank you.
Thank you. Very good. Very good. So
okay, the next one is Elahe. Is Elahe yes or okay?
Hi.
Hi.
Do you have my voice?
Yes.
I'm Elahe, and I want to answer. Systematic review, I think this is a review for that gives us the choice to complete and collect the reviews and analyze the health, and it's give us the choice for relevant individual studies, our health related issue. And I think it's important for us because of evaluate and identify the health problems or the health analysis.
Okay, thank you.
Thank you. So you're from?
I'm from Iran.
Okay. Which university?
But I study in Azerbaijan in Baku University.
Okay, so okay, thank you.
So the last one, Mohammed.
Yes.
The next question, please.
Thanks. Goodbye.
Goodbye. Thank you. So, Hussein, we should go to the next question.
Yes, yes, please.
Yes. Okay. The next question is about the same question, but this time about randomized controlled trials.
So,
what are the main criteria for critical appraisal of randomized controlled trials?
The main criteria. Okay.
You have the opportunity just to do a quick search in the internet, because we don't see what you are doing. So it's so easy. Just
So
type the main criteria for critical appraisal of RCTs, and you will
nice
find
teacher.
something. And
I like you.
You can do it, because the aim of all these things is just to learn. Okay. So if you can just
Where is Asama?
Okay, who is the first?
Randomized controlled trials. Randomized controlled trials and the main criteria for them. Okay, Asoma, yes. Nazanin also. Asoma, please wait for Nazanin. Nazanin, please start.
Well, a randomized controlled trial should have included and excluded criteria. So we should consider which characteristic must be included in participants and must be excluded. For example, for pregnant women, is it pregnant women, or should we exclude the people with immunocompressive diseases, such as lichen planus or etc.
And the other one is Ali. Where are you from?
Nazanin, you were from?
I'm from Iran. I'm from Gilan University.
Okay.
So, two from Gilan by now. The other Ali. Ali, yes.
Hello.
Yes.
Thanks for your time. For randomized clinical trials, we should consider some criteria like randomization, blinding, or masking.
Excellent.
The follow-up the patient's outcomes, and also analyzes biases in the study, and some criteria like this.
Excellent.
Thank you. You are from?
Isfahan.
Isfahan.
Okay.
Yes.
Okay, Iran.
Medina.
Yeah.
Thank you. And just one other question. I think many of the criteria now have been presented. Just maybe if you can complete.
I think that randomized controlled trial is about like two groups, and there are also two groups, like experimental group and the other is conventional group. And there, I think that randomized trial is about like examining information, but very carefully, like because that's the evidence that we are finding, and this evidence must be like really effective, and the information must be really accurate, and and I think because RST, as I know, the goal is to minimize like the risk of factors of confounding these factors that can, for example, affect the results, like have an influence the results.
Thank you. And Mohammed, is there any other question, or is it the last one?
There are two more questions.
So
just, the last student, I could not see her name.
Abdul Rashid is the last. Medina was from
Azerbaijan.
Okay, Azerbaijan. And the last one is Abdul Rashid. And for this question, please. Abdul Rashid. Yes, stop. We hear you. Abdul Rashid.
We can hear you.
Abdul Rashid, are you there? Okay, so continue to next question, please.
Next question, yes. We have the same question about cohort studies. And I think you know cohort studies. What are cohort studies?
Abdul Rashid, do you know the answer for cohort studies? No. Your microphone is off. Mohammed, the time is over.
Okay, so maybe the next question, the next student.
There is no.
Okay, this is the last question. We will forget about the next question. It is about case control studies. So if just one student can use this opportunity to get some scores for his or her country. So telling something about cohort studies. Yes, we have one.
Okay. The only one is Fateh Mohammadi-Nejad, the last one. Okay.
Okay.
Please.
Just please.
Fateh. We cannot hear you. You can write, Fatima, if there is any problem, or Median. Okay.
The next student, if you just open the microphone for her.
Hi.
Hi.
Yeah, I'm Media. Hi. If I want to give you,
Stopped.
Cannot hear you.
Media. Gita.
About most of things,
okay,
and
okay.
valid evidence can benefit and risk of health care, and
Nadia,
essential to.
Nadia, just sorry, we could not hear you. I mean the first sentences that you
Unfortunately, I'm stuck in Iran, and it's because of Iran internet. I'm sorry. I said that if I want to give you some, some information about some general information, cohort study can provide valuable information or invaluable from randomized trial. But I think the readers have to know and have to alert about some possible flaws. Valid evidence can benefit and risk healthcare in intervention, and it's essential to graduation decision making. Randomized controlled trades are control trades are considered the best method for providing an evidence on efficacy. However, the phase important, essential, and logical concentrate can have been criticized for forcing unhealthy selected.
Thank you.
You're welcome.
Okay, thank you. So.
And which country?
I'm from Iran, but I'm studying in Azerbaijan University, Baku.
Very good.
And I want to be in Azerbaijan team, Iran didn't accept us, so I want to be I want to play in Azerbaijan team.
Okay, very good. So you are from Azerbaijan. So
the winner is Azerbaijan, I think. The number of from how many of us?
So I think now we should close the competition, but just I will review some of the things that you told and you explained. Some of your answers, which was very good, and covering the aspects I wanted to cover. But just I want to do a review and then finish my presentation, maybe about 10 minutes or so. Can I have 10 minutes?
5 minutes, please.
5 minutes, okay, thank you. Okay, so we are talking about reviewing and critically appraising the evidence. We talked about the hierarchy of evidence, as some of you truly mentioned. At the top, we have a well-done systematic review, including 2 or more randomized controlled trials. So if in our search, we could reach an article which is a well-done systematic review of 2 or more randomized controlled trials, this can be at the top of the hierarchy of evidences. And in the next level, we have a randomized controlled trial. Both of these types of studies are expensive, time-consuming, and difficult to run, as all of you know. In the next step, we have cohort studies, then case-controlled studies, then a dramatic uncontrolled experiment. And you can see how much important is having a control group. So when you don't have a control group, then the level of evidence come to this point even after a case-controlled study which is just an observational study and not an interventional study. And then we have reports of expert committees and opinions of respected authorities. And then someone once told me, we have one other, and the majority of today's clinical practice is based on the last 3 types of study, unfortunately. Then maybe a more complete evidence ladder, high quality systematic reviews at the top, large randomized trials with clear-cut results. So when you have clear-cut results, it provides good evidence for you. Then we have small randomized trial with uncertain results. For example, positive trends without statistical significance. Then for the next level, we have non-randomized trials with contemporary controls. So the trials, non-randomized, but they have contemporary controls. Then we have non-randomized trials with historical controls. And then we come to observational studies, first cohort studies, and then case control studies. Then dramatic results from uncontrolled studies. For example, treatment of infection with penicillin in the 1940s has been based on these types of studies. Then we have case series and other descriptive studies. You know, they are descriptive studies. And then reports of expert committees and opinions of respected authorities. And then at the last level, we have something based on clinical experience. So when we are talking about papers that they are about therapy, these studies are mainly randomized controlled trials. So the best study that can answer our questions regarding therapy, so the questions that we have about therapy, two interventions regarding therapy. The best study that can provide us with some evidences is randomized controlled trials. And these are the main criteria and general criteria to appraise controlled trials. So the first one is, as you said, was the allocation of patients to the study groups random. So we can check it in the methods part. Were all the patients who entered the trial accounted for and analyzed at the end of the study? We told about follow-up. Were patients, clinician, and study personnel blinded? Then it is possible. Were the groups similar at the outset and treated equally throughout the study? You can understand all of this by reading the article and mostly by reading the method parts, the methods part of the study, of the article. Were clinically important outcomes assessed? Sometimes the outcome is not relevant to clinical situation. And can the results of the study be applied to my patients or not? These are the general criteria for randomized controlled trial. And about systematic reviews, as Asoma said, was a clearly stated question asked? Can we define and determine PICO components of the question of the article? Were the inclusion criteria appropriate? Was a comprehensive literature search done? And was the validity or quality of the primary studies assessed? Was the assessment of the studies reproducible and free of bias? Were the findings of the studies combined appropriately? How are the results presented and what is the main result? How precise are the results and were all the important outcomes considered? And were the author's conclusion supported by the data? We should, when we are reading any original article and also systematic review articles, you should notice that the title of the article should be in accordance with its methodology and with its aim and with its conclusion. Sometimes there are some discrepancies between the title, method, aims, and conclusion. If we encounter such discrepancies, we can judge that and we can evaluate that the article is not a good article. So title says something, aims about something else. The methods that have been used for the study is not a good method to answer that question, and the conclusion is something else. This is not good. And will the results help in caring for patients or not? Then we have some question about a diagnostic test. So one of the categories was about diagnosis. So was the test compared blindly and independently with a gold standard? It is very important. Was the test evaluated in a range of patients representative of a clinical practice setting? You should check this. Did everyone who received the new test get the gold standard or not? Can the test be replicated in my practice? Can I use the result? Do the results of the test apply to my patients or not? And then we have something about causation, about etiologic factors or causation. Then were the comparison groups similar? Were the exposures and the outcomes measured in the same way in both groups? Because here we have usually two groups, like in cohort studies, like in case control studies. Did the exposure precede the outcome? This is important. Is there a dose-response relationship? So with higher, for example, dose, we have stronger responses or not? Does the association make sense? Sometimes it does not make any sense. And can I apply the result to my practice? You can see this last criterion is repeated in all of the checklists. Can I apply the results to my practice? So when we read an article, we should pay attention to this point. And then we have some question about prognosis. And we are reading some articles about prognosis, where the patients were described, representative, and at a similar point in the development of their disease. Was follow-up sufficiently long and complete, and were the outcome criteria explicit and applied objectively? Were the extraneous prognostic factors adjusted for? Because we are talking about just one outcome and one prognosis. Were the study patients similar to my own? Will the results help to select or avoid therapy or provide advice for patients? So these are some other criteria, just some general criteria. I don't want to repeat these ones because we went in detail for each groups of the study, but these are some general criteria. When you are reading an article, you can use them as checklists to see how valid is the article. And then, as I told you, at one of the most criteria is this one, that whether treatment or outcome has some relevance to clinical practice or not. Then there are some standardized reporting guidelines that we can use when we are, these checklists are for writing an article, but we can also use them when we want to appraise an article. You maybe have heard about consort checklist, maybe some other, you have heard about the other ones, for example, STRAB, MOOS, quorum, START, or MOOS. So for each type of articles, we have some standardized reporting guidelines. And you can find these checklists in the internet and use them. You can, for example, if you go to this site, consortstatement.org, you will find the consort checklist for randomized controlled trials. And you can use that checklist also for appraising clinical trial studies. You can visit also this, you can visit also this CAS. It is about, it is abbreviation of Critical Appraisal Skills Program. This is a website. It contains, in this website, you can find some checklists for different types of studies. So please check and visit this website, very useful. You can find very good checklists when you are reading an article. And and this is my last slide that's saying that many aspects of dentistry have been introduced without randomized controlled trials. And the example is dental implants. So it has been based on well follow-up study, but not controlled study. And the reason maybe is obvious, because it's so difficult to do a randomized controlled trial in dentistry. It's difficult to blind. It's often we face limited inclusion criteria. Sometimes it's not ethically approved. It's not ethically possible. These are the challenges of doing a clinical trial. In the absence of randomized controlled trials, we should try to seek the next best evidence and rely on it as much as possible, given the weaknesses. As we learned today, we should have this ability to critically apprise articles and documents we study. We should just not rely on the articles, everything in the article, because it's new, because it's in a prestigious journal, these are not criteria to appraise an article. Just we should use methodological and what we have talked about today when you want to appraise and critically appraise the articles. So thank you for your attention. If you have any question, I can answer. And also you can ask your answer to maybe sending emails to me. Or
question, please ask by email because the time is over, Mohammed. Next lecture is waiting.
Okay, thank you, Hussein. Thank you. I want to thank all participants. I hope they have learned something today. I tried my best to make you active, and then I will sum up the scores, and then we will announce the first the country in the first place of the competition that we have. Thank you very much.
Would you like to feel history, eminence, and cultural diversity in one place beside your academic experience? So, follow my story. Tehran University of Medical Sciences is the most highly ranked medical university of Iran, one of top-ranked universities on Shanghai and QS ranking as well. TUMS is a city of science with a history over 100 years. Being pioneering clinical and scientific fields based on a large number of developers, scholars, clinicians, and students have made it a distinguished center with a notable reputation in the region and Central Asia. Our campus doors are open to international students from all cultures and backgrounds. To provide equal opportunities for talented students, exceptional offers including scholarships and financial assistance are available. After graduation, you will return to your country and will start to practice, research, or teach. Outstanding and passionate faculty members are our assets to have qualified curriculum and educational system. Meet the opportunity for a new academic experience in an amazing university in wonderful Iran. To do so, take the step to apply for TUMS. Now the admission is open. Don't hesitate to act for a better future. We can't wait to see you here.
Okay, for the next part, we have Professor Ahmad Reza Shamshiri. Yesterday, he talked about search engines and websites that are important for searching the literature, and now he continues the last parts of the evidence-based dentistry. Ahmad, please start. The floor is yours.
Hello, everybody. Thank you, Hussein. Do you have my voice and my presentation on the screen? Yes, thank you very much. So I start my presentation about interpretation of evidences. Okay, we are here in fourth step of evidence-based practice, and I will speak about strength of evidences and related recommendations and role of evidence in clinical decision making. Unfortunately, this step of evidence-based practice doesn't offer any systematic approach, and there is no specific methodology to interpret the knowledge you gain from the resources However, there are some hints and points you can find, for example, in clinical guidelines that guide you to rely on the strength of the evidences which recommend some decisions about your questions. So I want to have a look at the early steps of evidence-based dentistry. Generally, we speak about three main points in evidence-based practice. The relevant scientific evidence, maybe you hear from me, the best available evidence, the clinical judgment or expertise, and patient's value and preferences. So, and this is adopted for evidence-based dentistry, the same definition, an approach to oral health care that requires the judicious integration of systematic assessment of clinically relevant scientific evidence relating to patient's oral and medical condition and history with the dentist's clinical expertise, it means your clinical expertise, and the patient's treatment needs, preferences, and values, okay? And here, for example, when you want to get your answer from a paper, a systematic review or clinical trial or any ones, you should at first methodologically evaluate the paper, as Dr. Khami previous lecture speak about the topics that you should critically appraise the papers. For example, is the evidence from known or reputable source? For example, Cochrane Library is a valid source for systematic review papers. Has the evidence been evaluated in any way? Is there any critical appraisal for that papers or not? Also, it should be up to date enough to answer your question. And how was the outcome measured? And is that a reliable way to measure the variables is related to the methodology? If no, you should put away the paper, and if it's yes, you should think about that the result of the paper, is the recommendation of the paper clinically important? How large was the effect size? If you see something about the effect size in evidence-based dentistry, you should focus on clinical importance, because effect size have an statistical meaning that is not considered here. So you should think about that the implication of the results of the paper, is it relevant to your setting and your patient or not? If it's not appropriate, so again, put it aside. And if the answer is yes, finally, you should think about the statistical significance. So first of all, you should check the methodology, then you should think about the clinical importance of the results of that paper. And at last, you should check for a statistical significance. For example, you should check the p-values, and more important than p-values is the confidence intervals of the effect size, okay? So if it is approved by a statistical method, you can rely on the conclusions of that paper. So here you can see the recognition that research evidence is a valued component of the clinical decision-making process, and the intent is that the use of current best evidence does not replace clinical skills. So you should rely on your clinical expertise, and it's very important. For decision making, it's not enough only to rely on the papers and even guidelines. You should rely on your expertise together with best evidence. Okay. And the weight of the evidence is differ. For example, if you get a strong evidence, so the weight of the evidence on your decision should be high. And if your evidence is weak, for example, you have no clinical guidelines, you have no systematic reviews, and there is no randomized controlled trials in that field, you should rely, for example, on expert opinions, and it's a lowest level of evidence in that case. So your clinical judgment overweight the scientific evidence. Is there any question?
No question, just problems.
Yeah. Okay. And here we have some level of evidences. For example, Oxford Center of Evidence-Based Medicine provide this escalation for systematic reviews and meta-analyses of randomized controlled trials. They named 1A. As I mentioned yesterday, systematic reviews are secondary research, and they are critically appraised primary researchers to produce a systematic review and meta-analysis. After that, we have randomized controlled trials as a primary research study, and they name 1B. The next one is related to observational studies that we have almost no control on data, and they name it the second level of evidence. The third is for case control studies and cross-sectional studies. The fourth is related to case studies, and the last one is for expert opinion. So as you see here on the right side of the slide, the error and bias increase when you go down through these evidences, and the validity increase when you go top. However, there is a question: is always randomized controlled trials are the best evidence for any clinical question? Maybe some of our questions couldn't be answered by randomized trial. For example, if you want to study for a risk factor, and I mean a harmful exposure, is it ethically sound to expose a group of people to the risk factor and follow them to see how many of them became diseased, and another group without that exposure, and compare the incidence of disease between them? It's actually unethical. So when you look at the area of the questions, for example, for therapy, for prevention, and for diagnosis, for etiology and causation and risk factors, and prognosis, you can see we have different best evidences for them. Actually, for therapy and in some cases for diagnosis, we can perform clinical trials and we can follow the patients to see the differences between different interventions and, for example, conventional and routine methods. However, for prognosis, it can't be possible. We should understand the differences between different areas of our clinical questions and the best evidences. Maybe in some cases, cohort studies with enough long follow-up durations is the best evidence. And in that case, it's not true to search, for example, a randomized controlled trial. I have two examples from two clinical guidelines. The first one is evidence-based clinical practice guideline on antibiotic use for the urgent management of pulpal and periapical related dental pain and intraoral swelling. It's from ADA. It's maybe some confusing. It's consists of 3 parts. The first one is the certainty of the evidence provided by grade group. The grade group categorized the certainty of evidence in 4 categories. The highest certainty category is defined as we are very confident that the true effect lies close to that of the estimate of the effect. It means with further studies, well, we don't, we predict that we don't change the effect and the conclusions are consistent for a long time. The second one is the moderate certainty. We are moderately confident in the effect estimate. The true effect is likely to be close to the estimate of the effect. Yeah, I put the reference for this categorization below left of the slide. The low certainty, our confidence in the effect estimate is limited, and the last one, we have very little confidence in the effect estimate. So when you read a clinical guideline, and if you remember, the clinical guidelines are at the top of the level of evidences for practitioners. So if there is a little strong evidences, maybe the clinical guideline recommend based on evidence with low certainty. So here we should rely on our expertise with these few evidences. However, for those with high level of certainty, we could rely more to those recommendations provided by the clinical guidelines. Here is the second part, that interpretation of strengths of recommendations implies for patients, for clinicians, and for policymakers separately. For example, the strong recommendation for patients is most individuals in this situation would want the recommended course of action, and only a small proportion would not. Or for clinicians, the same strong recommendation, most individuals should receive the intervention. So they provide some strength of recommendations and conditional recommendations that they provide here. And finally, you see here, there is 2 recommendations that indicated by very low certainty of the evidence, and some of them are strong recommendations. I mean the second one, and for first one is the conditional. So in good clinical guidelines, they provide some hints for users to make best decision making for the patients. And the second one, because my time is over, the second example is about non-surgical treatment of chronic periodontitis by scaling and root planning with or without adjuncts. And here they are provided different escalation for strength of recommendation. As you see, strong in favor, weak, expert opinion, optional for, expert option against and against. And here they provide some recommendations below, and in front of each one, they show the level of strength of recommendation. Okay.
Thank you.
Here, you should pay attention to the effect size that they provided by some measure of associations. I mean, mean differences between groups, mean changes by percentages, odds ratio, risk ratio, and so on. And I have a question about number needed to treat. Here is my question, but I have no time. Number needed to treat, say, with new intervention, how many patients you should treat to get one advantage from the conventional method. So with low number needed to treat, you get the better results in your practice. And here we focus more on, we emphasize on clinical importance or effect size rather than statistical significance. And I think it's better to stop my presentation further. And if you have any question, I'm here to answer you.
If you let us, Ahmed, you can answer in the room to the question, because we have another session at 4 o'clock, and we should close the panel at 4 o'clock.
Okay, okay. So, thank you very much. Have a nice time.
Thank you, Mohammed, and that was a very nice presentation. And now we have a short break, and after that, I start. Now, I start my presentation. Happy here to have you here, and in the nice afternoon, in the weather that is like a spring here in Tehran. I start my presentation. So the title for my presentation is Social Determinants of Health. Yesterday, today, and the upcoming days, we talked and will talk about the dentistry, the prevention, and all the techniques and topics about the dentistry. But for whom should be and can we provide these services? And where are our patients? I just want to give you an explanation about the people we are working for them. In this presentation, I speak about the health and determinants and definitions of social determinants and models explaining social determinants of health, and also about oral health inequalities. What is health? Health is multidimensional. It's not merely the presence or absence of disease. You know it very well, but it also has social, psychological, and cultural determinants and consequences. The World Health Organization defined health as a complete state of physical, mental, social well-being, and not merely absence of disease or infirmity. And in recent years, this statement has been amplified to include the ability to lead a socially and economically productive life. So you see that definition of health is developing according to the life circumstances in the countries and different types of the countries. So, but about the definition of oral health is also multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions like this and that, with confidence and without pain, discomfort, and disease of the craniofacial complex. But you're talking about oral health. For whom? Look at this picture. Is she understanding the meaning of oral health? If somebody is in need of basic needs of life, when do you think that she understands the meaning of oral health? It's just when she has a toothache and she puts her hand on the mouth and here like that. She understands that there is something in the mouth is named tooth. Health is at several dimensions. There's physical, good teeth, a good tooth, and also mental, a good mind, a positive mind, a social, emotional, and vocational, and other dimensions also it has. So newly is introduced different dimensions for wellness. From that physical, mental, and social, they develop it to 9 dimensions: physical, emotional, intellectual, spiritual wellness, as well as social wellness, environmental, occupational wellness, financial wellness, and cultural. So you see that the meaning of oral health and health is widening more and more. And what about the determinants of it? Determinants of it are factors influencing the health of the individual or population and are known as determinants of health. For example, services, health services, or aging or gender, other factors. And you should know that no risk occur in isolation, and many have their roots in complex chains of events spanning long periods of time. Each event has its cause and may have many causes. So, where should we find the determinants of health and what are they? For that, I would like to ask you to find your country and see what is the gross domestic product of your country. What is the GDP? This is a standard measure of the value added created through the production of goods and services in a country during a certain period of time. You can search in the Google and find the GDP of your own country. The other word is health expenditure. This is total health expenditure as percentage of gross domestic product, GDP. So how much of money that is produced in your country is devoted to health by the government. This percentage is total health expenditure. And amount of that, how much is devoted to oral health expenditure. So these are the factors that determine the level of oral health in any country. And you can search it in the Google and find your GDP, the GDP of your own country, health expenditure of your own country, and oral health expenditure. And the other thing that I would like to say, that the word society, you know that society is derived from the root word socios, meaning individual, and societa, meaning group. Society is a group of individuals who have organized themselves and follow a given way of life. So all of you and us are a society of dentists. And we are a society that have this type of life. And in sociological terms, society refers to a group of people who live in a definable community and share the same culture. Our culture is dentistry. But if we go outside the university and outside the dental office, our culture is something that is in the streets and in our home. On a broader scale, society consists of the people and institutions around us. Now we are in the Institute of Dentistry, so we are dentists and our culture is dentistry. If we go to our home, our culture is something else. And what is social environment? Human social environment encompasses the immediate physical surrounding, social relationships, and cultural milieus within which defined groups of people function and interact. You work and interact with your classmates. So you have the common culture with your classmates. And now all of you are our classmates and are of a common group. Components of a social environment include built infrastructure, industrial and occupational structure, labor markets, social and economic processes, wealth, social, human and health services, power relations, government, race relations, social inequality, cultural practices, the arts, religious institutions and practices. All of them are our social environment. And about the social determinants of them, health. Social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age to death. And the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. For example, numerous studies suggest that social determinants of health account for between 30 to 55 of health outcomes. Something, if you remember, yesterday, Professor Heikki Mortoma also mentioned that about 50% of oral health outcomes depends on the behaviors that behaviors that are shaped in these social surroundings. And if we want to give you some examples of social determinants of health, is income and social protection and social insurances and health insurances, education and the level of education in a community, unemployment rate and job insecurity, working life conditions, food insecurity. That's very important. Housing, basic amenities and environment, early childhood development and the conditions, social inclusion and non-discrimination, structural conflict, and access to affordable health services of decent quality. So these are some examples of social determinants of health. So, and if we want to give an example, a framework for social determinants of health, we can see here that how they have arranged these determinants. And if you want to give an example of health inequality, there is a health inequality in any community. One of them is gender inequality and gender pay gap, that how much a community pay to the different genders, male and female, in any community. And this gap exists anywhere. And inequality also in oral health. If you look at this mess of cables, so what do you think about that? Or in such a condition, how do you think about oral health? Can you focus on oral health here, or here, or here? What's your idea about oral health in these circumstances? So you cannot think about oral health here. And also in such a occlusion, what do you think about oral health? Isn't there anything more important than dental caries, or here, or here? So there are something else different than dentistry that you can think about that. And health disparities and oral health, that's a very important thing that you should focus on. And about dental caries, usually education and income and occupation is very important, and influence on the level of dental caries in any community. And among affluent countries, income inequality exists. And early childhood caries continues to be a social, political problem in many countries in the world still. And periodontal diseases as well. Among socially disadvantaged population, the prevalence of periodontal diseases are still high. And also about oral cancer, risk factors for head and neck cancer, such as tobacco, alcohol use, and other risk factors are likely to be increased in low-income communities due to uncontrolled social determinants of health. And early detection enhances effective treatment options, but such services are limited among disadvantaged minorities, particularly men in underserved areas. Thank you for your attention, and this is the end of Community Oral Health panel. The member of department will answer you whenever you send us in an email or contact us, and we welcome any candidate or any question or any cooperation with each of you. Thank you and goodbye.